and the honor to open this scientific session. For the first speaker, it's Monsieur Alain Françon, Arceli Musel Garcia, Isabel Santos, Errol Forestier, Romain Forestier, spa treatments and reduction in the consumption of analgesic and anti-inflammatory drugs in rheumatology. What is the evidence, review, and randomized clinical trials? Je vous prie, monsieur.
Thank you very much. First of all, I would like to thank the organizer for inviting me in this nice place. Thank you to Olga, thank you Constantin, thank you all the organizers. I present this work. This work is that work of the Research and Center of Aix-les-Bains with an international team, as you can see maintenant. And the title of the presentation is Spa Treatments and Reduction in the Consumption of Analgesic and Anti-Inflammatory Drugs in Rheumatology. What is the evidence? Review of randomized clinical trial. On one hand, analgesic drugs, paracetamol or acetaminophen, opioids, or anti-inflammatory drugs, NSAIDs or steroids, are very often used in rheumatology to relieve acute or chronic pain. But their effectiveness and their respective tolerance is currently open to discussion. The main adverse effects are on the digestive tract, liver, kidney, drug withdrawal, and so on. In the other hand, the main objective of spa treatments in rheumatology are to improve pain, improve function, improve quality of life, and reduce the consumption of analgesic and anti-inflammatory drugs, and thus to reduce the side effects of these. And the question is, what is the current level of scientific evidence concerning a reduction in drug consumption by spa treatment in rheumatology? A beginning of an answer is given by this study, a real-life Italian multicentric medico-economic study called NIAT survey with 98 Italian spa centers and more than 6,000 spa patients with osteoarthritis. And one of the study criteria was the consumption of analgesics and NSAIDs in the 12 months preceding and the 12 months following the spa treatment. And the result for this criterion was the percentage of patients with regular consumption of analgesics decreased from 42% to 25%, and the percentage of patients with regular consumption of NSAIDs decreased from 71 patients to 48 patients. It was significant. But there were weaknesses in this study. There was no control group. There were retrospective data. There was a selection bias because the survey only studied patients who had been treated with a spa treatment for 2 successive years. So we carry out a systematical review on randomized clinical trials with the objective to evaluate the effect of spa treatments on the consumption of analgesic and anti-inflammatory drugs in rheumatology with the highest level of evidence, which is randomized clinical trial. We are in all right with the motto of the Congress, evidence-based balneology. So we made a systematical review with a bibliographic search from the Medline, Embase, Cochrane, Pedro database. We include randomized clinical trial published up to December 2023, evaluating in rheumatology SPA treatment or a combination of SPA treatment versus a control group without SPA treatment. We exclude publication not in English or French language, studies with only abstract, studies with without statistical between group comparison, and studies without evaluation of drug consumption. And the outcomes studied were pain and the drug consumption of analgesic, NSAIDs, and steroid. We analyze the results indication by indication. So we found 105 randomized clinical trials, and one in French and 104 in English. We exclude 75 trials, 14 without statistical between group comparison, 50 without information or precise data about analgesic or anti-inflammatory drugs consumption, and it was a pity. 11 for which in the protocol of the study, the consumption of analgesic and anti-inflammatory drugs was prohibited during the study or during the day preceding the assessment. So we include 30 randomized clinical trials with assessment of consumption of analgesic, NSAIDs, or steroid, 10 in knee osteoarthritis, 8 in low back pain, 2 in hand osteoarthritis or neck pain, or fibromyalgia, or spondylarthropathy, 1 in hip osteoarthritis, or shoulder pain, or rheumatoid arthritis, or several pathology, polypathology with radon treatment. Knee osteoarthritis was the more evaluated with 10 trials. And you see here the table with, in the first column, the name of the first author and the years of the publication. In the second column, the SPA treatment assessed. It was mineral water, mineral mud, mineral water and mud, or multiple therapeutic intervention in SPA. And in the third column, the treatment of the control group. In the fourth column, you have the results of the statistical comparison between SPA group versus control group. When the results was positive and show reduced consumption of drug, it was highlighted in green. And when it was negative, it was highlighted in purple or red. For pain, it was the same thing for the drug consumption of analgesic and NSAIDs. So we found 7 trials with reduction of both pain and consumption of analgesics and or NSAIDs. And this effect was persistent in 6 trials from 2 months to 12 months, depending on the follow-up of the trial evaluation. In one trial, there was a reduction of both pain and consumption of analgesics, but without reduction of consumption of NSAIDs. In one trial, a reduction of consumption of analgesics and without reduction of pain. And in the last trial, a reduction of pain without reduction consumption of analgesics and NSAIDs. But at the start of the study, the percentage of patients using analgesic was very low. It was at 22%. So we conclude that in knee osteoarthritis, there is a good scientific evidence that SPA treatments permanently reduce the consumption of our analgesic and NSAIDs over several months up to a maximum of 12 months. In hip osteoarthritis, we found only one trial with a low statistical power, only 29 patients included, and without positive results. So we conclude that in hip osteoarthritis, there is no scientific evidence that past treatment reduce the consumption of analgesics and or NSAIDs. In hand osteoarthritis, we found two trials, including one with a positive result at 6 months and another without positive result. So we conclude that in hand osteoarthritis, there is low scientific evidence that spa treatment reduces the consumption of analgesics and or NSAIDs, but drug consumption appears low in this pathology of hand osteoarthritis. In chronic low back pain, we found 8 trials. 4 trials with reduction of both pain and consumption of analgesics and or NSAIDs. And this effect was persistent in the 4 trials from 3 months to 12 months, depending on the follow-up of the trial evaluation. In one trial, there was reduction of both pain and consumption of analgesics without reduction of consumption of NSAIDs. In another trial, a reduction of both pain and consumption of NSAIDs without reduction of consumption of analgesic. In another trial, a reduction of consumption of analgesic without reduction of pain. And in the last trial, reduction of pain without reduction consumption of analgesic and NSAIDs. So we conclude that in chronic low back pain, there is a good scientific evidence that spa treatments permanently reduce the consumption of analgesics and or NSAIDs over several months, up to a maximum of 12 months. In chronic neck pain, we found 2 trials, and none of these 2 trials show a reduction in pain and consumption of analgesic and NSAIDs. And the French trial of Forestier show greater effectiveness of the control treatment by pulsed electromagnetic wave on pain, but not in the reduction in drug consumption, which was equivalent. So we conclude that in chronic neck pain, there is no scientific evidence that spa treatments reduce the consumption of analgesics and or NSAIDs. In chronic shoulder pain, we found one trial which show a reduction in pain and consumption of analgesic and NSAIDs at the end of spa treatment, but not at 3 and 6 months. So we conclude that in chronic shoulder pain, there is low scientific evidence that spa treatment reduce only in the short term the consumption of analgesics and or NSAIDs. In fibromyalgia, 2 trials. One trial shows a reduction in pain and consumption of paracetamol at 6 months, while another does not show a reduction in drug consumption. So we conclude that in fibromyalgia, there is low scientific evidence that spa treatments reduce the consumption of analgesics and or NSAIDs. In ankylosing spondylitis, we found 2 trials. The 2 trials show a reduction in pain and consumption of analgesic and NSAIDs. So we conclude that in ankylosing spondylitis, there is middle scientific evidence that spa treatments reduce the consumption of analgesics and or NSAIDs. In rheumatoid arthritis, we found only one trial with radon bath, and radon bath does not show a reduction in pain and consumption of analgesic, NSAIDs, and steroid until 12 months. So we conclude that in rheumatoid arthritis, there is no evidence that radon bath reduces the consumption of analgesic, NSAIDs, and steroids. And the last trial with radon therapy in several rheumatic disease, it was low back pain, osteoarthritis, rheumatoid arthritis, ankylosing spondylitis, or in the same patient, several pathology. And in this trial, radon bath and or caves allow a reduction in pain and consumption of analgesic and SIDs until the 9th month. So there is low scientific evidence that radon bath or cave reduce the consumption of analgesic and or NSAIDs. We look at the associated factor with a reduction of drug consumption. So pathology assessed, knee osteoarthritis, chronic low back pain as we saw, and with a lesser degree ankylosing spondylitis are associated to a reduction of drug consumption. The nature of the SPA treatment assessed. SPA treatment alone, mineral, water bath, or mud, or in combination are both effective. Nature of the comparator, it's important because we found in the trial of Forestier that pulse electromagnetic field in neck pain appear more effective than SPA treatment. The number of patients included in the study, many patients give greater statistical power, which make it easier to show a difference, a statistical difference. The number of randomized clinical trial published, more positive publication, and more evidence. And the importance of drug consumption at the start of the study, the higher the initial consumption, the easier it is to show a significant reduction. So we can ask this question: is it useful and relevant to evaluate the consumption of analgesic and anti-inflammatory drugs? Maybe, maybe no, because this consumption can be very low in certain SPAS patients and for certain pathology, as we saw, osteoarthritis of the hands, with 5% of patients. And some randomized clinical trials have prohibited patients from consuming analgesic and anti-inflammatory drugs. So this makes it possible to better directly assess the effect of the SPA treatment on pain. Donc, why not? Therefore, why not? Yes, probably yes. Because the consumption of analgesic and anti-inflammatory drug is very closely linked to the understanding of the evolution of the other outcomes, in particular pain, and its absence is likely to invalidate the conclusion of a study. And second, showing a reduction in drug consumption is particularly interesting because the population of past patients is often an elderly population with one or more comorbidities, which particularly expose them to the risk of serious adverse of these drugs. So the take-home message in the conclusion, first, only 40% of published randomized clinical trials have evaluated the consumption of analgesic NSAIDs and or steroid and have published the result of this outcome. Second conclusion, second message, the results of this trial show that SPA treatment reduces pain. This pain reduction is most often associated with a reduction in the consumption of analgesic and or anti-inflammatory drugs permanently over several months. Third, the best evidence concerning an analgesic effect of SPA treatment allowing a reduction of drug consumption are in knee osteoarthritis and chronic low back pain, and to a lesser degree in ankylosing spondylitis. And fourth message, in the future, any randomized clinical trial evaluating the effect of SPA treatment in a painful pathology should necessarily include an evaluation of the consumption of analgesic and anti-inflammatory drugs with publication of the result of this outcome. Thank you so much for your attention.
Thank you for your have answered question after the
So I call Mr. and Mrs. Pucani, Nachi, Ariani, Biasi, Gozzi, Gorla, Macaroni, Massiero, Muratore, Quarta, Thierry, Vitale, Vidogni, Fioravanti, Viducci, for the presentation, impact of balneotherapy on pain, function, quality of life, anxiety and depression in fibromyalgia syndrome, an Italian prospective observational multicentric cohort study.
I will present to the role of balneotherapy in primary fibromyalgia syndrome. I will talk a lot about the clinical part of the disease. Let's see how important it is. It's really widespread in the world. As we can see, the prevalence is estimated to be between 2 and 4%, affecting more women with a ratio of 7:1. And in Europe, we find specific prevalence in countries such as France, Germany, and Spain. It is defined as a rheumatic disorder characterized by widespread pain, fatigue, and sleep and mood disturbance, with associated presence of specific palpable tender points. We can see the difference between its classification in the International Classification of Diseases, where in the 10th revision, we find it under the other soft tissue disorders, while in the 11th one, we can find it under the chronic widespread pain, enhancing the importance of this symptom in the pathology. Going through the symptomatology, we can divide it in cardinal features, which are pain, fatigue, and sleep disturbance, mainly, and then other common features such as psychiatric symptoms, depression, anxiety, and morning stiffness, also migraine, headache, or stomachache, and many more. That's why we call it syndrome. And on this, the basis of the syndrome is characterized by a nociplastic pain, which is different from the nociceptive and neuropathic, and it has no clear evidence of tissue damage, causing this activation of peripheral nociceptors. We can find this type of pain also in other syndromes, other diseases, such as the complex regional syndrome type 1 and the irritable bowel syndrome. And we have many ways to test the nociplastic pain, where the questionnaires are the most used in clinical practice, as we will see later. The etiology of this disease, it's still unknown, but on the hypothesis, we find a central sensitization, both with a peripheral sensitization, where the first indicates an anomaly in pain processing at central levels, and it's defined as a state of persistent neuronal hyperexcitability to a peripheral stimuli. Also, we find the oxidative stress that can play a critical role in fibromyalgia pathophysiology, because there were being found high levels of nitric oxide, lipid peroxidation, and more that can cause the pain sensitization. At the same time, there have been studies on the dysregulation of cortisol circadian variation, and we'll see later that balneotherapy is effective also in this. Then more hypotheses goes around the elevated levels of substance P, of glutamate, and an altered activity of opioids, and a decrease of serotonin, noradrenaline, and dopamine that can also cause like more working of the nociceptive system instead of the anti-nociceptive one. How we diagnose it? We use the widespread pain index and the system severity scale combined one with the other in the new criteria, ACR criteria, American College of Rheumatology. in the widespread pain index, I don't know how it works. The patient expressed his regional pain in different areas associated with the symptom severity, where we can find all the different symptoms that we already talked about. So to diagnose, we combine widespread pain index symptom severity score combined with a generalized pain and symptoms lasting more than 3 months, excluding other diseases. Let's go to the treatment. So far, we follow the new EULAR recommendation, which are the European recommendation for many rheumatologist disease. And we can, they recommend a complex, multidisciplinary and multimodal treatment with a combination of non-pharmacological at first and then pharmacological therapies. For what concerns pharmacological treatments, there's a different combination of analgesic, anticonvulsant, antidepressant, and muscle relaxant. And as it regards the non-pharmacological treatment, we combine physical therapies with psychological therapies and other non-conventional one. And in the EULAR recommendation, we also find thermal therapy. We find the hydrotherapy, but because they don't distinguish between hydro and balneotherapy. So talking about more balneotherapy, how does it work in the fibromyalgia? There's a combination of factors even here. First of all, the pain is relieved to the thanks to the pressure and temperature of the water on skin, which can improve muscle tone, reduce pain, stiffness, and muscle spasm. Also, the heat of water stimulates the production of hormones. As we said before, there's a lack of cortisol explained in fibromyalgia and has shown effectiveness in countering oxidative stress. Also, the increase of beta endorphin has an analgesic and antispastic, which can explain part of it. We have found different randomized control trial for balneotherapy in fibromyalgia, but with only one double-blind randomized control trial. And we can find the balneotherapy inside the Delphi consensus recommendation for the treatment. We went through this meta-analysis and systematic review, which found all the explaining all the randomized clinical trial regarding the pain measured by visual analog scale and the fibromyalgia impact questionnaires, where we found an improving statistically significant in VAS pain at 2 weeks, which was maintained at 3 months and at 6 months. And the same for the fibromyalgia impact questionnaire. On the other hand, it wasn't that maintained in the tender point count, because it was maintained at 2 weeks, but not at 3 months, but not statistically significant at 6 months. But we already know that tender point count, it's not that reliable as for monitoring fibromyalgia. On all this basis, we developed the FibroTherm study, which was supported by the scientific group of Italian Society of Rheumatology for the evaluation of balneotherapy in rheumatic disease. Our aim was to investigate the impact of balneotherapy on pain, function, quality of life, anxiety, and depression. We enrolled, we're going to enroll even more patients with primary fibromyalgia in a rheumatological rehabilitation unit in our hospitals in 15 different centers in different regions in Italy. Our inclusion criteria, to go fast, will be a diagnosis of primary fibromyalgia according to the ACR criteria, will be adult patient with a pharmacological, with a stable treatment for at least 3 months and with a moderate disease activity. Yes. Then the participant will be stratified into 2 groups. a balneotherapy cohort who will receive a cycle of bath or mud bath therapy once daily for 12 days, and a control cohort, which are the included patients who couldn't receive the cycle of therapy because they refuse it for personal reasons. We are gonna include 260 patients for each group for a total of 520 patients. To be included in the study, the thermal intervention must be carried out with sulfurous, sulfate, bicarbonate, saline or sodium chloride, and arsenical ferruginous mineral waters, according to our classification of Marotta and Sica. And the main endpoint of the study will be achieving the MCID at 15 days, defined as 14% of the change in their baseline of the questionnaire, fibromyalgia impact questionnaire. And secondary endpoints, we find the persistence of clinical efficacy over time up to 6 weeks, the change of the other scales that we're gonna see, and the tolerability by recording all the adverse event. So each patient will be assessed at baseline after 2 weeks and after 6 weeks using the visual analog scale for pain, the fibromyalgia impact questionnaire, and other questionnaires for health, anxiety, and depression, which are all validated in Italian. So to conclude, from literature, we saw a significant efficacy on pain, functional index, sleep, and quality of life, lasting a long time until 3-6 months. And we saw how balneotherapy was well tolerated and had a lower percentage of side effects. Our conclusion: we don't have the results yet of the study, but in our hypothesis, there will be a superior proportion of patients experiencing MCDI in the balneotherapy cohort compared to the control cohort. And the aim of our study, so it's to provide new insights into the role of balneotherapy in improving both algo and functional symptomatology, quality of life, and anxiety depressive symptoms, which are the main features of fibromyalgia syndrome. Thank you.
Thank you for this presentation. And now we are calling. Now we are calling Mr. Giorgio Perdikaris. Calcium, vitamine D, magnesium, can vitamin D, magnesium, and calcium save our skeleton?
Good evening, everybody. So this presentation changed 5 times before I presented. The last time was yesterday. So 5 times. So I decided today that I will show you all the references in the beginning, and we will go through them together. I'm not going to give a lecture and talk about every specific paper. Don't worry, everyone who wants the papers, I will show you at the end a WeTransfer link that you can download all the papers. And it was a very interesting study that I did. I learned a lot. If you ask me something and I tell you the answer, I have absolutely no idea from which paper I took it. It's impossible to remember. But I found new knowledge, old knowledge. It was really interesting. So The first thing I wanted to talk about was vitamin D, because I love vitamin D. It's the vitamin of the sun. We all know that we activate it in the kidneys. Well, it's not only that. All the cells of the immune system are taking directly 25-hydroxyl vitamin D from the blood and are activating inside according to their needs to make defenses and cathelicidins and to do what they're doing. So it is really important to have the levels of 25-hydroxyl vitamin D high in our blood. I'm always confused with numbers, and the first thing we learned in chemistry, my first degree, is how to put it in order. So remember, 1,000 units is 25 micrograms. 25 nanomole per ml is 10 nanogram per ml. And that's easy. Then you can do the transaction in your head. We cannot talk about vitamin D without mentioning Dr. Holick, the actual person who isolated 25-hydroxy vitamin D. Is an interesting story, read it. Vitamin D is everywhere in the body. And I did 1 year of rehabilitation medicine as a resident in Greece. I used to have a supervisor who was saying, if you pick up a stone inside the body, any stone, under that you will find vitamin D. In 2014, Paul Wegerels and Paul Ekwaru took the raw data that the Institute of Medicine took in order to announce the RDAs for vitamin D, and they found a statistical error at the magnitude of 10. So when we are talking about 400 units of vitamin D, we should be talking about 4,000. And when we are talking about 800 units of vitamin D, we should be talking about 8,000. And you will see that in order to succeed a level of 40 nanogram per ml in the blood, you need to take around 9,000 international units per day. Anyway, 10,000 per international units per day is the dosage that is advised from the Endocrine Society to be taken. And it's been shown to be safe when given for 6 months. The levels of PTH became normalized also within 6 months. Very important for vitamin D to remember is you should take it daily and not in bolus dosage. It changes the outcome. Of course, parathormone, we need it to be less than 45. And another effect that we saw is that when you are taking 10,000 international units per day, you are affecting epigenetically around 1,289 genes. Where only with 4,000 units, it's only 320 genes affected epigenetically. You know, inside the body, we have the nutrients, what it needs to function, and the way of function. This is epigenetics. This is more important than the genetics, is my understanding. Why is it important to have a high level of vitamin D? If you check the hazard ratio for death from all-cause mortality goes to 1 when vitamin D is more than 50 nanogram per ml in the blood. And a very nice graph. You can pick your disease. Every arrow is a disease. When you go home and you can check where the arrow goes and in which level of vitamin D in nanogram per ml in the blood, you will have lowered that disease to 0. Here is also, in the levels of vitamin D, a very big problem with the RCTs that are describing vitamin D. It was very well described where I saw the lecture from Dr. Stefan Pilz in the European Congress of Endocrinology, who explained that most of the RCTs, they are starting with a baseline level of vitamin D that is already in some kind of sufficiency, and the dosage that they give is not enough to cause changes in the concentration of the blood, so the result is inconclusive. And in that Congress, there was a call to all public health authorities to increase the RDA of vitamin D to 7,000 units per day from all sources. Of course, if we want to take it from food, and I will keep only one thing from here, is if you want to eat farmed salmon, to take 4,000 units, you need to eat 3.2 kilograms. But if you go and you buy wild salmon, you need only 500 grams. Something is wrong with farming. This slide exists. It's not connected with my presentation, but it's a very interesting clinical study. I'm showing it to everyone. They took healthy children that were positive antibodies for diabetes type 1. They were all became negative with the use of vitamin D and analogs. Now, the second idea I had to do the presentation today was to focus more on osteoarthritis and on the bones and how the bone is forming, and to use the piezoelectric phenomenon that when it's combined through exercise with weightlifting, it's combined with vitamin D, you have much better results. I think you know that. The third idea was to talk about the rehabilitation of the immune system and the metabolism with an extra focus on chronic diseases like osteoporosis, osteoarthritis, rheumatoid arthritis, which is my favorite actually. And to present to you the algorithm of good health, how to drink water, which elements, which nutrients you have to have in which substances, in which level, how to eat and how to sleep. Still, something was missing. So the fourth idea I had to present today, as I was looking for osteoporosis and arthritis and everything, I end up going to the past. So let's go for a trip to the past in 1986. So we go to Dr. Newnham, not a medical doctor, Dr. Newnham. Okay. This specific paper was submitted in 92, but he says over 30 years, and we will study a little bit with him, over 30 years of accumulating evidence indicates that boron is essentially for healthy bones and joints. Both epidemiologic and control animal and human experiments suggest that boron supplementation in amounts found in some diets throughout the world is effective in preventing or treating various forms of arthritis. The initial observation was that, in the next slide. Okay, in these slides, we see that in 1941, in the diet of the people, they were taking 10 to 20 milligrams of boron per day. In 1986, that was 0.25 on institutional diet in USA. It's a big difference. The original observation was like in countries with very low concentration of boron in the soil, like Jamaica, less than 1 milligram, we had 70% incidence of arthritis. Where in countries with very high boron, like in New Zealand, the last one, which is more than 10, we don't have arthritis. That's Dr. Newnham, and in 1986, he sent a letter to the Arthritis Trust of America, the Rheumatoid Disease Foundation, saying, calcium supplements, I'm reading it, it's the only paper we will read together because I want you to see the feelings that I have when I first read that. Calcium supplement sales are at an all-time high as women try to prevent bone loss. Unfortunately, only a certain type of bone, the cortical bone, are being strengthened from the added calcium intake. But the trabecular bone loss is not affected by calcium supplementation. At that time, a professor from Harvard, the professor of nutrition, Dr. Mark Hegstead, stated that osteoporosis looks like a dietary problem, not a calcium problem, and that you need magnesium, boron, phosphorus, silicon, etc. And we continue because the foundation asked from doctor to review the paper that they received. And these are the comments. He says, Dr. Newnham states that the parathyroid gland contains more boron than any other tissues in human. Actually, he wanted to say that boron for the parathyroid glands is like iodine for the thyroid glands. Well, he says that I have noticed that approximately 65% of rheumatoid arthritis patients and 25 to 30% of osteoarthritis patients undergo the Hirschheimer reaction when treated with boron. He was urine borax. In his research, he verified the fact that arthritic patients undergoing treatment with boron supplementation often experience the Hirschheimer reaction, and that reaction is always a good prognostic sign. Bear with me a little bit. In the last 15 years, 60s, now we're talking, we are in the past, something over 500,000 people have used the boron food supplement tablet so as to get rid of their arthritis. Those who have rheumatoid arthritis generally experience an early aggravation when there is more pain. This is called, as we mentioned. Now, the remedy is working, but they must persevere, and in another 2 or 3 weeks, all the pain and swelling and stiffness has gone. The American Human Nutrition Research Center has shown that a similar boron supplement will reduce the daily loss of calcium by nearly 50%. And this would mean that the victims of osteoporosis would live longer and be free of pain and discomfort. And my favorite, that if someone can help me find this clinical study, I will thank him. I didn't manage to find it. In the mid-80s, a double-blind hospital trial was conducted in Melbourne that showed these boron tablets were very efficacious and quite safe. The authorities were looking for ways to stop the use of boron supplements and did many pathological tests which all proved the complete safety of this supplement. If someone can help me find this study, I will be. So, is it that the advances that we made are harming our food? I don't know. Where is that good apple that all doctors are afraid of? You know, in the papers from the 80s, a good apple contains around 22 milligrams of boron. In the same papers, they say that the farmed apples have less than 1. So the good apples existed, but the doctors are afraid. But also, they were not as juicy as today, and they had less sugar inside. This is for other. Look on the screens. This is for other fruits also. On the left side, the first and the second pineapple is boron deficient. The third one is boron sufficient. So it seems that the taking of boron should be the first thing to do to prevent or cure this disease. Now let's go back to the future. Nothing boring about boron. 2015, I highlighted the most important things. It is a very beneficial because it is sparing testosterone, 25-hydroxyvitamin D, and 17-B estradiol. They say that probably is because it's regulating the reaction of the 24-hydroxylase. Also, they made a clinical study. They gave a high dosage of boron, I think 10 milligram, and they were measuring the blood values every 2 hours for the following 6-8 hours. And they found a peak at 4 hours and the drop in high sensitivity CRP and TNF-A. Also, boron helps, and this is the most important thing that I will explain in more detail, helps the antioxidant enzymes like superoxide dismutase. And when you are hunting inflammation, you need to have antioxidation, okay? So this is superoxide dismutase. You see the enzyme folded. In the active site, it has copper in the depth of the active site and zinc in the surface of the active site. Now zinc goes around. It's regulating 300-400 enzymes, is fighting viral infections, so he can live. When he lives, still is folded the protein, but is inactive. But is very important. So the organism has a secondary pathway of activation through glutathione. Now, glutathione is formed from an acetylcysteine, which is an antidote for paracetamol. Now, if you put all these things together and you have a patient with a very high viral disease, very, very heavy viral disease, that you give him paracetamol, you are depleting all the antioxidant system. There are some factions how zinc is affecting and is fighting different viruses. You will check it if you are interested. Now, back to the boron. Also, has therapeutic effects against a number of cancers like prostate, cervical, and lung cancer. It helps also ameliorate the effects of traditional chemotherapeutic agents. The NIH, remember the good apple, 22 milligrams of boron, says that the upper level for an intake of boron in healthy individuals, 19 plus, is 20 milligram. I don't understand something here. So the question is, did we harm the food and we named it normal? I don't know. I mean, don't get me wrong. First of all, I was a chemist. My first degree is chemistry. I mean, I love chemistry. It's my life. I grew up inside chemistry. It explains everything. And literally everything. But what happens with chronic diseases? Why we haven't managed to erase from the planet the chronic diseases? Oh, we're looking about calcium. Calcium comes from the food and from the bones. Where it goes? Is it wandering around? Can it be trapped in the muscles and we name it, I don't know, fibromyalgia? Can it be trapped in the eye and we name it cataract? Can it go outside the bones or to the points that there are pressure and creates osteophytes? I don't know. Maybe I'm wrong. The point is, we keep calcium. And we need also magnesium. Well, I don't think there is a need to mention the benefits of magnesium. You have to know that talking with boron and magnesium, we need a very increased amount of magnesium to be in order for the better function of boron and of vitamin D. Personally, I use Sarengari, the magnesium chloride. By the way, magnesium, I learned from a professor here in the university when I was studying, magnesium, iodine, and sulfur are best absorbed from the skin. And that takes us to where? At the end, to the rehabilitation of the immune system and the metabolism. We supply the biological machine that we are calling body with the nutrients that it needs, and then we have to regulate also the function. The patient must make a decision. In our first question, are you ready to give up the things that make you a patient? If the answer is yes, then we need to be able to tell to the patient how he will create new habits that will fight the old habits. We are human beings. We cannot fight habits. The new habits will fight the old habits. We just give power to habits. Be careful where you give your power. And in order to do that, according to Hippocrates in ancient Greece, you were not able to work to take your license as a doctor if you didn't prove that you firstly cured yourself physically and psychically. That was the final exam, examen de residenciat. That was. Because you need to know also history. He says, foolish is the doctor who despises the knowledge acquired by the ancients, and let food be thy medicine, and medicine be thy food. Because when you do the things with the target of being healthy, then the body will get rid of weight as a side effect. Also, if the body needs to take weight, will take weight as a side effect. And finally, I'm presenting to you the algorithm of good health, who says simple things: how to drink water. Now, the quality of water is a whole presentation by itself. I'm not going to go on that. When to drink water, how to eat, when to eat, what to eat is something that usually I'm not touching with some people, because if they follow the previous things, they don't need to change. They become better. And you need to be careful your basic nutrients, basis of life. B12 needs to be around 1,000. Vitamin D needs to be around 60 to 80. Folic acid needs to be around 20. Zinc and copper needs to be in balance. Okay, magnesium 2.2 in the blood test is very sensitive, although only a very small percent of magnesium is in the blood. Check the thyroid, balance the thyroid with selenium and iodine. And for the patients that don't know these things and they see us, please find someone to help you do these things. Don't do it by yourself. One time I had a friend who took by herself, from accurate understanding, 6 times higher dose of zinc, and we end up with metallic taste in the mouth. I was really scared at that time. So I would like to have a paper here saying also boron. Maybe we can set up a clinical study like that. So my total understanding for everything is that, let's see how many people will understand this. Our vitamin D is a hero. This is my understanding. And if we give here the correct things, meaning boron, magnesium, vitamin K2, it transforms to a superhero that can regulate the calcium homeostasis, among other things. Thank you very much.
Just ευχαριστώ. Thank you very much for your very interesting and exciting presentation. Thank you for your exciting presentation, and I can assure you that it was not at all boring.
If anyone wants to have all the papers that I used for the presentation and a PDF of that presentation, it will be valid for 7 days. And you can download, I put all the papers, like 5, like PDF, all the papers I used. And even more. And I put also a PDF from a presentation that I did specifically to provide an information. Okay, thank you very much.
Thank you. Now I introduce Monsieur Romain Forestier, Alain Françon, methodology of clinical trials in balneotherapy and hydrotherapy. Je vous prie, monsieur.
Thank you to the organizing committee to give me the opportunity to present you some ideas and suggestions for the evaluation of balneotherapy. So, at first, I will say that we usually use non-drug therapy by comparison to drug therapy, but my opinion is that we should mainly we should prefer comparing industrial therapy versus artisanal therapy, because they are different with non-drug therapy like balneotherapy. Of course, we are sharing the problem of evaluation with rehabilitation, surgery, and various forms of physiotherapy. And so, what is special in balneotherapy evaluation? One of the problem is the blinding of participants, because as you know, blinding of participants is influencing the result of the study. But there is also another special issue, which is standardization. When you take a drug, for example, all the pills have exactly the same composition. When you deliver physical therapy, you have the hand of massage, the temperature of the mud, the length of the bathing sessions. It's not really standard, and it is influencing the signal to noise ratio, because when you want to find the difference between two results, you need to have the result of the mean, but also of the standard deviation. And if there is no homogeneity in the treatment, the standard deviation is higher. And we will see also that financial resource is impacting the statistical power of the study. And of course, when the market that you can deliver the treatment is bigger, you have more financial resources to perform good clinical trial. So in these different therapeutic modalities, you see drugs, physiotherapy, surgery, physiotherapy, rehabilitation, and balneotherapy. You can have a blinding of participants, therapists, patients, and examiner for the drugs, and for physiotherapy also. For example, if you have a device which is giving pulse electromagnetic fields or infrared, with a working device or not working device, the patient cannot see the difference. So it's not a distinction between non-drug treatment and drug treatment, but between artisanal and industrial treatment. Surgery, you can have blinding of patients, but you don't have the blinding of therapists. Of course, the surgeon have to see what he's doing. And in physiotherapy, rehabilitation, and balneotherapy, you can have the blinding of therapists, of the examining physician, but not from the patient, because he knows he received the treatment. For the standardization, you have you can have big standardization in the two first cases, but not in surgery, physiotherapy, and balneotherapy. And as you know, when you find an efficient drug, the market is the world. So you can send millions of pills. So the money that you can invest in the research is not the same that if you are a small rehabilitation center with maybe 5,000 patients each year. So your market is 5,000 patients. It's not 2 or 3 or 4 billions. So we have a little more resource in France because the spa center were forced to make the evaluation of balneotherapy. The French government said, if you want the balneotherapy to be reimbursed, you have to work together to make a good evaluation. So we are quite lucky in France to have this money, but it's not. I know it's not the case in most of the country interested in balneotherapy. So this introduction is made. So as you see, balneology is a whole treatment with a balneotherapy component and a balneotherapy effect, which is rest, physical activity, change of lifestyle. And you have also in balneotherapy effect, the effect of the chemical composition of mineral water, the physical property of mineral water, heat, radioactivity, pressure, buoyancy, and the effect of associated treatment, massage, shower bath, and exercise, and blinding possibilities are not the same. For the chemical composition of mineral water, you may have a blinding of patients, but in fact, when you know how it's working, for example, our water in Aix-les-Bains is yellow. It's not transparent. So the blinding of patients is quite hypothetical. You can have a blinding of therapists if you tell the patient not to tell the therapist that he's a member, a participant in a clinical trial. And of course, you can have a blinding of the examining physician if you tell the patient not to tell which treatment they receive. So the bias in clinical trials, as you know, can be described as systematic error that can result in false treatment effect estimate. So the bias may cause an investigator to misinterpret the result of any research finding. We will see what kind of bias we can reduce. First, we discovered that if you choose a qualitative primary income, for example, significant improvement versus not significant improvement, you are less influenced by the placebo effect. It's the meta-analysis of Objartson that you can see under. He was comparing the placebo effect, he was comparing placebo treatment versus no treatment. And so he showed that in that case, with a binary endpoint, you don't have much influence of the placebo effect. In the case of patient-reported outcome, there is a slight overestimation of the effect in the absence of blinding, but it's a small effect, so I think it's better to use this kind of judgment criteria. The simplest model of evaluation is the open study. It's the example of the El Khayyam study published a long time ago in 1991. And you can see for osteoarthritis, they evaluate pain at movement. And it's decreasing along the study until 24 weeks. But in that case, we are not sure that the result is the effect of the treatment because of the historical bias. It becomes a bias when other factors external to the subject and different from the treatment occur to the passage of time. For example, you are evaluating the knowledge of some students, and so you make a lesson, you want to evaluate the effect of your lesson, but at the same time, you have a drug company which is giving a different message, which can influence the answer of your student. So it's the historical bias. You have also maturation bias. It can be biological or psychological change that may occur in the subject itself. For example, if you make a study on weight in growing children, of course, you will find an increasing of weight of the children. That is not the result of what you're doing about the subject. The test bias can also occur when the changes response are due not to the treatment, but to the fact that the patient is tested several times, especially when you have a very complex questionnaire. The first time the patient doesn't understand so much, but the second time it understands a little better, the third time also. So it makes a difference in the answer that is not the result of your treatment. That's why you also, have the instrumentation bias when the change are not related to the treatment, but to the calibration of the measuring instrument. And the most common mistake we can do is to change the examining physician during the study. If it's not the same people which is asking the question, he will probably not asking them exactly in the same way, and it can induce difference. And also you can the regression bias, because usually when you are performing a clinical trial, you are including patients which are in a crisis, in a bad situation. But even if you do nothing, parts of them will improve. For example, when you have a knee osteoarthritic crisis, we know that 6 months later, maybe 20 or 30% or 50% of the patients are getting better. I have the experiment 2 years ago. I couldn't go down the step for maybe 3 months. And 6 months later, I was doing a table tennis competition without any pain. And I didn't take any drug. So this regression bias needs to be also evaluated. That's why we are making comparative study. And you have the example of the NOL study that we performed and published in 1997 about low back pain. And we had, you see the people, balneotherapy patients are in red. The control group is in green. And there is a difference, which is small, but which is significant. But in that case, we were asking people to make the balneotherapy treatment, the control group, after the end of the study, like waiting list design. And finally, we lost big part of the patients in the control group because the most painful patients run out of the study in order to have the balneotherapy immediately because they had too much pain. So you are losing information by losing the most severe patient. It's a possibility. So that's why in the control trial, the advantage of control trial, they help to control some described bias, but they are more expensive because you need twice as much patients. And you still have some biases that we will talk. Here you see, you have the balneotherapy, the control group, balneotherapy group is in red, is improving, but the control group just has the placebo effect and the regression to the mean. So it's the selection bias where that occurs when subject cannot be randomly assigned to group. So the comparability of group is not the same at the beginning. Or if you combine mortality bias, attrition bias, when you lost to follow-up, some patients that are more severe than the one are staying in the study. So we can call it selection bias interaction when there is a combination with selection bias and experimental mortality. That's why we are proposing, it's a French pharmacologist, Jean-François Collin, which proposed to perform the waiting list design. So if you propose to the control group to have the balneotherapy treatment at the end of the study, so they will not leave the study even if they have too much pain because they are expecting a treatment at the end of the study. It's the example of the Guillemin study performed in 1994, and they had 102 patients recruited about the spa area. They were randomized in 2 groups. 50 patients received the treatment at the beginning of the study and 52 at the end of the study. There was a blinding of the examining practitioner, and it's measuring the effect of the spa technique because all the people were close to the area, so they didn't have a change in lifestyle in that case. And as you can see, the result is significant for most of the judgment criteria: duration of pain, intensity, hand-ground distance. When you try to touch the ground, when you have low back pain, it can be very painful. Schober index, Waddell score, it's a questionnaire about low back pain, one of the most questionnaires that we know. You have in that case also decreasing in painkiller consumption and NSAID consumption. But the Waddell score was not significant at 6 months. So the waiting list design is a little better, but it also has some inconvenience because in theory, you have the control group which is not changing in the first session, the treated group which is improving in the first session, and then as we know, the balneotherapy treatment is not efficient for 1 year. So if you see 1 year later, usually the people return to the initial value. And then you have the difference with the second group, which received the treatment. But in fact, when you observe what is happening in the reality, you see that sometimes the control group is decreasing his status. And probably it's the fact that they have a kind of deception bias because when they are in front of the examining practitioner, they say, yes, you asked me if I am better, but I didn't receive any treatment. So how can I be better? So it's a bias which is overestimating the difference between the two treatments. So it's, as I said, it's the evolution of the control group with the demoralization bias. We can call it like this. So a solution could be to compare the balneotherapy with another validated treatment. It's the example of treatment. We have some example of this, but I took this one that we published also in 1997. And 101 patients with osteoarthritis of the hand, blinding of assessment. It was a practitioner which was coming to the home of the patient, and the patient was told not to tell what they receive. And we were comparing mineral water cloud, which is called the Berthollet technique, on the hand, and ibuprofen topic, which had before a few positive double-blind trial. And the Berthollet was a little better than the topic at 20 days, and at 6 months, some of the judgment criteria will still improve compared to the control group. It was not the, unfortunately, it was not the main criteria. This is the Dreiser index. It's a questionnaire evaluating hand osteoarthritis. But as we can see, the evolution of the two groups are quite different. So we have another comparison that Alain talked about a few minutes ago. In blue, you have the control. The pen is increasing in the control group. No, I think I make inversion. I'm sorry. In blue, you have the pulse electromagnetic field on the left here. It is pulse electromagnetic field. So the pen is decreasing. You have the balneotherapy group for neck pain, which is improving but less than the pulse electromagnetic field, and the control group, which is not quite changing. And it's the opposite for the healthcare consumption. The control group, which is now in blue, I'm sorry, I made a mistake, is still increasing his consumption. The balneotherapy group is between the two, and the pulse electromagnetic field is still okay. It's not spending too much money to the treatment, because they were really better. So the limit of the method is that the standard treatment is not always available or validated. So it's a problem when you don't have a reference treatment. It's not solving the preference of the patient. So we will see later what could be a preference patient design. And it's more difficult to show a difference between two active treatments. So equivalence study is not so much interesting, because you never know if the lack of difference is due to the lack of difference between the treatment, or the lack of statistical power. So it's better to show that the treatment, the balneotherapy, is better than the reference treatment, and it's not easy. So a solution could be Zelen randomization, that is, or an equivalence, which is the blinding of hypothesis. In this method, you made the randomization before obtaining the the randomization is performed before the consent of the patient. And then when you ask the patient, you tell the patient in which group he will be, the patient is allowed to refuse the group and to choose the other treatment. But when you make the statistical analysis, you keep the patient who changed the group in the initial group where they were randomized, in order to keep the comparability at baseline. Okay, I'm not going too fast. If I'm going too fast, you tell me. It's where you have under here a few publications explaining this. So if he accepts, he is given the information exclusively about the treatment provided in his group, so you don't have the deception bias. And if you refuse the proposed treatment, he's offered the alternative, but analyzed in the group in which he was randomized. We have the example of the Termartro study that we published in 2010, long time ago now, with Professor Roch and Alain, some patients, some other colleagues. 460 patients. One group has home exercise. The second, home exercise plus spa therapy, balneotherapy treatment, which was mud application, water exercise, mud, shower, and massage. And Berthollet, because in Aix-les-Bains we have Berthollet, but we also made the study with two other big spa centers in France, Ballaruc-les-Bains and Dax. There was a blinding of randomization. Zelen was applied, the Zelen method. Blinding of therapists. The therapists didn't know that the patients were the part of a clinical trial. The patients were told not to tell that they are participating in a trial. The statistical analysis was performed by a university center, which is not involved in balneotherapy. And we made binary criteria for the results. And as you can see, 630 patients were screened, 462 randomized, and finally we could analyze 186 patients in the control group and 195 in the balneotherapy group. So you see that finally balneo is not so attractive for neosteroids patients because most the balneotherapy group have more people changing to the home exercise group than the opposite. And the result of the main criteria, which was at 6 months, that we observed much more patients with significant clinically important improvement, 51% versus 36. The result is similar at 9 months and at 3 months. You see also the evolution of pain, which is decreasing in the control group, as should do a control group, because when the control group is not improving, it means that something is happening in your trial that is not okay. And of course, and also the WOMAC function was improved. So the Zealand randomization, I'm sorry, I forgot to translate the first part of the slide. It can produce a kind of blinding in the control group because they don't know the existence of another group. So it's decreasing the demoralization bias. But you need for the control group to develop a credible treatment, even if it's not so efficient. And that's why we choose the home exercise program, because there was a publication showing that this home exercise program specifically was improving the pain and the function of the osteoarthritis patient. And since you are people changing group, you are a loss of statistical power. So you have to include a little more patients. So it's more expensive, of course. Other disadvantage, it's what we said. You reduce the difference between the group if there is a difference between the two treatments compared. And you have also a dilution of the treatment effect if patients are allowed to continue your usual treatment. It's when you make a explanatory study, you start with both groups exactly the same, and you are expecting that during the study, nobody, for example, will take a drug that can improve the pain instead of your treatment. But it's not a realistic situation. And we think that it's better in a trial to allow drug consumption, but to measure it in order to know if the improvement is not the result of the drug consumption, but of the treatment. So another methodological solution that has never been applied, but could be a solution, it's cluster randomization. So when you have numerous center of recruitment, you can choose some center which the control treatment and some center with the active treatment. It's the so it's preserving the blinding of the subject of the study. Unfortunately, you don't have blinding of the examining physician because he knows in which group he is. But with self-questionnaire, it's better to have blinding of the patient. So it allows patient blinding. It's accepted by the ethic committee. The Zelen randomization, sometimes it's difficult to explain to the ethic committee how it's working. And the disadvantage is that you don't have blinding of the assessment unless the recruiting center is different from the evaluation center. You need also a large number of centers, which is not very possible for small balneotherapy center. But if you have many balneotherapy centers participating in the study, it's possible. And you need also a larger number of patients because in one center, there is usually a correlation between the response of the patient, because maybe they talk in the waiting room. I don't know the reason, but in fact, it's usually happened that some center have a kind of same response that the other center. And it increases the risk of selection bias because each center is making recruitment with his own personality sometimes. It's not exactly objective, the recruitment. So the last solution that I will talk about, but it has never been performed also, it's the preference randomization. The idea is to ask the patient before starting the study, which kind of treatment they prefer. For example, if it's balneotherapy versus home exercise, we ask the patient, what kind of treatment do you prefer? If we prefer the balneotherapy, he's receiving balneotherapy. If he prefers home exercise, he receives home exercise. And you only randomize the patients who don't have preference about a treatment. So you have the answer, what will be the result for the patients who prefer the treatment A. You will have the result of what happened when you give treatment B to the patient who prefer treatment B. And you also may compare the two treatments because it's not it's not decreasing the results because of the lack of preference. The only problem of this is that, of course, you need much more patients in your study, and so it is increasing the price. Thank you.
The methodological approach for a good predictive evidence base, and also emphasizing the aspect that health doesn't have a price, but has a price. Et pour la bonne bouche.
I have the honor of introduce the professor Olga Surdu and his team, her team. Ah non, non, non. Pardon, bon. And her team. Elena Tukmeanu, Traian Virgiliu, Surdu, Monica Surdu, Virgiliu, Aline Yulun Tukmeanu, Janina Lungu. And the presentation is artificial intelligence, a fleet or opportunity for balneal medicine. It's okay.
Good afternoon. In recent decades, technology has made remarkable progresses, and artificial intelligence has become a central component in many fields, including medicine. While AI promises to bring significant innovation in healthcare, there is still a general misunderstanding about how it affects certain medical fields, such as balneal medicine. It is crucial to objectively evaluate the impact of AI in order to take advantage of its benefits while ensuring that the fundamental principles of balneal medicine, which emphasize human nature and personal interaction, remain central in the treatment process. The early days of AI were between 1960 and 1918. Today, AI is more powerful than ever, thanks to advanced in machine learning algorithms and access to large data sets. The modern capabilities of machine-generally classified AI include understanding human speech, competing at the high level in strategy games, autonomous vehicle, intelligent routing in content distribution networks, and military simulations. Artificial intelligence represents the ability of a computer system to perform tasks that usually require human intelligence. EA is capable of learning and adapting to new information and situations autonomously. EA using machine learning algorithms and data processing techniques to analyze information and draw conclusions. It can make decisions and make predictions based on data analyzed. For example, an NI system for facial recognition can learn to recognize new faces and improve accuracy with which it identifies people in images. In balneal medicine, EA can define as the use of algorithms and machine learning technologies to analyze medical data and provide personalized recommendation for balneary treatments. In contrast, conventional software is composed of programs and applications that are pre-programmed to perform certain functions and tasks. Conventional software is a computer program with a pre-established functionality which performs tasks in defined and pre-programmed ways. It follows a set of fixed interaction and does not have the ability to improve or make autonomous decisions. For example, a photo editing software may have predefined functions for adjusting brightness or color, and the user must specify exactly what adjustments to make. In balneal medicine, the usual software can include patient management system, session programming application, and data analysis program. Today, we stand at the cusp of an era where artificial intelligence can transform and augment the balneology landscape through its ability to process vast data, automate tasks, recognize patterns, and generate insight at remarkable speeds. EA system can extend human capabilities like never before, with powerful computational abilities to analyze complex data sets. EA has the potential to amplify and enhance human expertise in balneology and natural therapies. There are a lot of types of artificial intelligence, narrow AI or weak AI, general AI or strong AI, reactive machines, limited memory, and the last one, theory of mind, This is when an AI system can understand thoughts and emotion, apply social intelligence, and adapt in behavior accordingly. This is a very challenging goal. Self-aware AI, this hypothetical type of AI system would have consciousness, self-awareness, and the ability to form abstraction about itself and internal states. Cognitive AI. Cognitive AI does not fit neatly into any single category from the types I listed previously. It is more of an approach or capability that can be incorporated into different AI systems architectures. Cognitive AI refers to artificial intelligence system that can mimic human cognitive functions like learning, reasoning, problem solving, perception, linguistic abilities, and other. The goal of cognitive AI is to create intelligent machines that can interact with humans in more natural and intuitive ways. So cognitive AI capabilities cut across and integrate different AI techniques like machine learning, deep learning, logic programming, knowledge databases to produce intelligent behavior that more closely mimics human cognitive. Cognitive AI could potentially enable narrow AI system as more general AI system in the future. Its aim is human-like intelligence rather than focusing on any specific task. So it doesn't strictly belong to any single category, but provides cognitive computing capabilities to AI architectures. Some key aspects of cognitive AI include natural language processing to allow communication in human languages, knowledge representation to capture information like humans, automated reasoning to use logic, form abstraction, draw inferences, machine learning to acquire knowledge and skills through experience, computer vision for visual perception and scene understanding. When it comes to medical development and application, certain types of AI are better suited than others. Machine learning, especially deep learning techniques, have shown tremendous potential in medical image analysis, disease diagnostic, drug discovery, and genomic analysis. Machine learning can identify patterns and make predictions from large data sets like medical scans, health records, and genomic data. Natural language processing can help produce and understand unstructured medical data like doctor's notes, research papers, and patient reports. It enables application like clinical documentation, medical question answering, and literature research. Knowledge representation and reasoning are useful for building expert systems that can capture medical knowledge and use reasoning to support clinical decision-making, diagnosis, and treatment planning. Cognitive computing, cognitive AI that combines machine learning with natural language processing, reasoning aims to mimic human-like intelligence. This could enable AI assistants that can understand medical context and interact with humans more naturally. Reinforcement learning can potentially be applied to areas like robotic-assisted surgery, personalized treatment planning, and clinical workflow optimization. For the field of physical medicine, rehabilitation, and balneology, certain types of AI will be particularly well suited. Computer vision and motion tracking, natural language processing, predictive analytics and machine learning, virtual reality and gamification, robotic assistance and exoskeletons, thermal mineral water analysis. Advantages: continuous learning and improvement, human AI symbiosis, preventive and holistic care, access and affordability, and integration of novel therapies. More important are the disadvantages that are trust deficit, loss of human expertise, ethical challenges, safety and validation, human EA relationship strains. Is it true that there is a certain contradiction between the loss of human interaction as a threat and the personalization of treatments as an opportunity in the context of using EI in balneal medicine? The explanation for this contraindication lies in how EA technologies are used in medical practicing. Implementing EA does not necessarily lead to a total loss of human interaction, but rather complements it. For example, instead of completely replacing human therapists, EA can be used to assist therapists in decision-making processes and personalized treatments. In practice, it could mean that human therapists work collaboratively with EA system to analyze medical data and provide personalized treatments while still maintaining essential human interaction during treatment session. AA technology can complement and improve medical practice without completely eliminating the human aspect of balneal treatments. AI represents more of an opportunity than a threat for the field of balneology, but it needs to be approached thoughtfully and with the right safeguard in place. On the opportunity side, EA has immense potential to augment and enhance balneology in several ways, like knowledge aggregation. EA can help systematically integrate, and derive insights from vast amounts of data on the therapeutic properties of natural factors like mineral waters, muds, climates. This can accelerate evidence-based balneological knowledge development. Personalized treatments by analyzing a patient's medical data, preferences, and constraints, EA can recommend tailored and optimized balneotherapy regimes drawing from its broad knowledge base database. Discovery acceleration, AE's pattern recognition abilities could help identify promising new natural therapeutic resources or combinations that warrant further study much faster. Patient empowerment. Conversational AI assist can help educate patients about balneotherapy options in user-friendly language, increasing engagement. Treatment monitoring AI technology like computer vision can precisely track a patient progress through rehabilitation exercise or therapies for adjustments. However, to be a true opportunity, EA needs to be implemented responsibly. In conclusion, EA presents an unparalleled opportunity to elevate and accelerate balnear medicine progress while maintaining its holistic founding principles. By harmonizing human expertise with AI computational power through ethical, thoughtful integration, we can unlock untold benefits for personalized care. The future awaits, one where humanity's ancient tradition merge seamlessly with cutting-edge technology to promote holistic well-being. The emergence of artificial intelligence and consciousness artificial intelligence is not accidental or the result of a malevolent project, but rather natural stages in the progress of knowledge and human development. Thank you.
Thank you for your very interesting presentation and also provoking for the future. And I recognize with respect all the technology and a very high technology here applied in your sanatorium. And I emphasize the hard work of your manager and your entire team to apply all the techniques for the well-being of the patient. And sure, AE will be the future for humanity. Thank you again. Thank you.
And we'll come back for discussion. So we can put the time, I think, 15 minutes we have for discussion. So I will take the microphone for the group. And yeah, one question.
One question for. It's. Congratulations for your presentation. I have just some question and possible suggestions. First, did you take into consideration the method used for the evaluation of symptomatic drugs consumption? Because there is a high heterogeneity. And then in the different paper, some paper from me, we use a different methodology to measure the consumption of this drug. Second, at the moment, there is a great interest in sex gender medicine. Did you plan a possible evaluation, a possible sub-analysis on the difference, the gender difference in the consumption of symptomatic drugs? Because this is the moment that the balneotherapy start to interesting in the gender medicine.
I try to answer your very interesting questions. Thank you to ask. Yes, it's the trials are very heterogeneous. It's a problem. It's not the same population. It's not the same treatment. But I try to get to the trial, the result of trial without without the measure of the measurement of the consumption. There is several measurement of assessment of the consumption of drugs, and the aim of my study was not to compare that. It's very difficult. There is a lot of heterogeneity, and it's one. I only want to see if the result of the study show a difference or not. It's what, but your argumentation is very, very, very important. And for the gender, I don't study. We have not the result of the gender in the study, in the publication. Donc I can't answer to this question, unfortunately.
Questions, other questions, only to the microphone, please.
Can you hear me? Great. Mine is not a question, but a compliment to the use of AI in supporting balneological development and applications. I remember in 2012 was the Congress in Spain, and there we took advantage of AI to design a software, an application that could help us underscore the medicinal value of water. And we gave it the name BalneoCheck. So you can Google that and flip through the abstract. So I just want to inform us that AI, rather than negate, will actually enhance our efficiency. Thank you.
Thank you. If there are other questions from the room? If not, we'll have a very, very short break of a few minutes, 2-3 minutes, and we'll prepare the room for our sponsors.